We can divide them into 4 general strategies: non-specific immune stimulation, adoptive cell transfer, immune checkpoint blockades, and vaccination strategies. The 4th strategy uses vaccinations. Unlike the BCG vaccine that we mentioned earlier, and which targets the immune system in a general way, these vaccines are used to direct immune cells very specifically to the cancer tissue. Several viral vaccines have shown promising results in clinical trials. For example, a weakened version of the herpes simplex virus, modified to produce an immune-stimulating factor, is being developed for melanoma and head and neck cancer. It's also possible to vaccinate with a patient's own tumour cells. Some cells are extracted, irradiated to stop them from spreading, and then engineered to secrete activating growth factors. When the cells are injected back into the patient, the growth factors alert the immune system to the cancer. But it's also possible to vaccinate with a person's own immune cells. For example, antigen-presenting cells can be taken from patients, matured outside the body, and loaded with tumour antigen. When the cells are reintroduced to the patient, the antigen stimulates other immune cells and helps them to recognise the tumour. The first vaccine of this type received FDA approval in 2010 for the treatment of some prostate cancers. It's known as Provenge or Sipuleucel-T. The other vaccination approaches are still experimental. The last few years have seen many promising developments in anti-cancer immunotherapies, but there's still much work to do. To help get drugs from the bench through clinical trials and to the bedside, scientists need to find better ways to judge the success of immunotherapies in patients and to work out the best dose. Right now, it's difficult to predict who might respond to a particular treatment, and some responses are only short-lived. If these hurdles can be overcome, then many more cancer patients could benefit from strategies that boost their immune system.